about to go live, and you'll hear me start the queue as soon as it does. Good afternoon, everyone in virtual land. Welcome to the third segment of PrideTT 21's eduQUEER, an entire virtual health fair on Saturday today. We're so happy for all of you all to be joining us. We've had two fantastic sessions this morning already, and we're here once again to discuss NCDs. As before, this is part of our ongoing program, over 30 events this year, all virtual, but ensuring that we engage with the community and our allies. And we're very happy to have partners on the programming that are bringing to you added value. Today's session will once again be hosted by Makeisa Edwards, who is a UNIPride's Vice Chairperson, and she will tell you a little bit more about UNIPride and herself as we start. And of course, we are joined with Dr. Karen Sealey and representatives of FPATT. We are so happy to have all of you all here with us this afternoon to share some critical information with our community and allies. As we shared in other places, the community members are still not as comfortable as they need to be in accessing healthcare. And unfortunately, in some cases, they cannot access healthcare equitably as would other citizens. So sessions like these are very instrumental in bringing them life-saving information. So without much more, Makeisa, I will hand over to you.
Hi guys, welcome back. Welcome back to our third segment. Number 3, 1 and 2 was so great. Remember that you all can log on to our social media platforms to view if you're now joining. Don't be alarmed. It's up there for you to see. You have not missed anything. Just reminding you all that this year's theme is PAHO, which focuses on the struggle and yet power of a woman and their history. And as Rudy said, I'm your host, and I like to bring you along this journey with us again and edifying and learning about health ailments and how it affects us and how we can combat it. This evening, I have with me the lovely Dr. Karen Sealey. So Dr. Karen Sealey is a physician planner, public specialist with a wide breadth of experience in public health administration and planning at the national and international levels. Before joining PAHO/PAHO, she was the Director of Health Planning in the Ministry of Health, Trinidad and Tobago. Among her achievements was the introduction of health services research and institutionalization of the National Research Review process. In her 26 years with PAHO, Dr. Sealey held several senior positions working at the national, sub-region, and regional levels. As the Caribbean Program Coordinator, she spearheaded the development and adoption of the Caribbean Health Promotion Charter, established the Awards of Excellence in Health Journalism, raised the profile of non-communicable disease, as we know as NCDs, and mental health in the national health plans, and published the inaugural edition of Health Conditions in the Caribbean. During her secondment to UNAIDS 2006 to 2009 as the Director of the Caribbean Regional Support Team, Dr. Sealey established the Caribbean Women, Girls, and HIV program and published the first regional comparison of programs towards the UNGASS indicators in the Caribbean keeping score. Karen Sealey returned to PAHO in August 2009 as the first special advisor for UN matters and partnerships. In the WHO office at the UN, there she provided technical support to the permanent missions from the countries of the Americas on health to the CARICOM group of ambassadors in the negotiation process leading to the adoption of the political declaration of the UN high-level meeting, HLM, on the prevention of and control of NCDs. Since her retirement, Dr. Sealey has completed several consultancies with UN agencies and government of Trinidad and Tobago in the areas of managing the NCD response, strategic planning, organizational development, and health diplomacy. She has also served as the executive technical advisor to the Minister of Health, Trinidad and Tobago. Dr. Sealey convened the Trinidad and Tobago NCD Alliance, which was launched in March 2017, dedicated to increasing the participation of the non-governmental sectors in the response to NCDs. Dr. Sealey is currently the director of Healthy Caribbean Coalition and interim president, Chest and Heart Association of Trinidad and Tobago, and has been a panelist in several international NCD and COVID webinars. Guys, so after a bio like this, I can't wait for you all to learn so much from Dr. Sealey. So I hand you over to Dr. Sealey. I can't wait.
Good afternoon, everybody. Let me just start the slideshow so I'll know where I am. I am really very, very, very happy to be here. And I can now say and reconnect with some of my friends, as I just did to Sharon. Thank you very much for that kind introduction. It was supposed to be just simply an idea for you to say two sentences. That's what I was told, but thank you. It's been a journey, and since I've come back, I've been trying to. Since I've worked on the international scene a lot, I've been trying to contribute at the national scene, on national level now, again, because I started off at the national level. So when I was asked to do this, pardon?
We're happy to have you back.
Thank you, thank you. When, in fact, Donna asked me to do this, she knew it would be a little bit tight, but I did it. Let me just say so. I mean, you know, I used to work for a boss, Sir George Allen, who used to say, there's never any problem when you can't do things, because we have to remember there are 24 hours in the day, and then there's the night. So who needs more time than that? So I have prepared a series of slides, and I think I'm going to take them in sort of modules, so that we can have some dialogue in between as we go. I never like to speak for more than 15 minutes, so I will try and break this up. So I'm not going to be talking all the time, and I'll go through the slides fairly quickly so that we can really to provoke thought and for us to discuss and for me to learn more about what your needs are with respect to NCDs. As you know, I'm right now chair of the Trinidad and Tobago NCD Alliance, and we have put people living with NCDs or living with people who have NCDs or taking care of people who have NCDs at the center of what we do. So it would be really, really helpful and valuable to both communities, yours and ours, for us to work together to make sure we can help to bridge any issues that you have with the Ministry of Health, because that's one of our roles as we go forward. So let me start. Okay, let me start here. Not going. I'm trying to start this. What should I use? This one. Nope. Okay. I usually use my. Okay, there we go. Okay, I'm going to focus on 4 non-communicable diseases. So by the fact that you're using the acronym NCDs, I'm very happy to hear that. And I hope that it means something to us. As I tell people, any disease that is not a communicable or infectious disease is most likely 99% of the time a non-communicable disease. Actually, HIV is the one that, because non-communicable diseases are also associated with chronicity over a long time, indeed, we do consider HIV one of the chronic diseases, not that are non-communicable, but there's a chronic disease. And so there's room for interaction between the two systems and also between the two communities who have these issues. WHO, PAHO, and the Ministry of Health have added a fifth disease to concentrate on, and that's mental health, which is, I mean, extremely important. We, at this moment in the Alliance, just because of our capacity, we are not including that in the work that we do. We hope to very quickly have a network of people, not only of organizations, and that network will be able to include people who have other NCDs other than the 4 that we have here, but who will be able to help us to see, in fact, the interface between these communicable diseases and the other diseases that they have, especially the autoimmune diseases, etc. What this chart is showing is that we have identified 4 common modifiable risk factors, and I'll take each of those words. I think you would agree they're common to the 4 diseases on the side, right? We see them affecting. The plus sign means that they are a risk factor for all of those diseases. And actually, you might think that the absence of the plus sign here, the absence of the plus sign here tends to indicate that alcohol is not important in chronic lung diseases. But in fact, we know that people who have a problem with alcoholism, right, undertake kinds of behaviors that put them at risk for chronic lung diseases. So these are the 4 we could focusing on. Modifiable. They are modifiable because individuals can take action within an enabling environment. I want to repeat that. Individuals can take action within an enabling environment to modify these things so that they don't get the other kinds of risk factors, including, for example, obesity. If you don't have physical activity and you're not having a healthy diet, you will be very high probability of becoming obese. And obesity itself is a risk factor for, or definitely cardiovascular disease, diabetes, and cancer. It is also a risk factor for chronic lung diseases because with obesity, it's more difficult to breathe, and you can understand that how that is also contributing there. But why I'm stressing enabling environment, you will see the link as I go on, it's because the individuals, families can only take action if the environment around them allows them to do so. The environment in which they live, work, play, learn. Those environments must be such so that they can take advantage of those environments. So I suppose the easiest one for us is people will consider healthy choices if they are affordable. And the affordability is something that the governments can control. And that is when I talk about enabling environment, when a government provides incentives or disincentives so that people can make these choices for these things easy, then it in fact is where they work with the governments provide enabling environment, and the population at the individual level and community and health level and family level can make the decisions as to what is good for their health once they're aware of that, and then make those choices. So common modifiable risk factors are these 4 that you will hear. I'm sure you've seen a lot in the Ministry of Health and in the campaigns: tobacco use, unhealthy diet that is high in fat, sugar, salt, and physical inactivity and harmful use of alcohol. I'm not going to go into more detail on those at the moment, just to say that when we did a fact sheet on the state of communicable diseases in Trinidad and Tobago, it's really bad. you can see here that the top causes of death are among the 4 diseases. And I want you to note that it is the heart diseases, the cardiovascular diseases, that is the one that is highest. There is a concern, there is a tendency to think that the number 1 is disease that is of importance and priority is cancer. But in fact, cardiovascular disease and diabetes are responsible for a higher percentage of our deaths than is cancer and stroke at this point. And it's hard for you to see the factors that are in there, but when we did a survey recently, we discovered that, for example, 90% of Trinidad and Tobago's population consume less than the 5 servings of fruits and vegetables daily. Right? That is 90% of the Trinidad population. So you have to, as you listen, you sort of check yourself as to where you are in the spectrum of these behaviors as we go forward. And I'm not going to go into all, but just to say, there's none that we can say we don't have a problem with. Right? We have a problem with alcohol, and now the recent research more and more is showing that, in fact, no alcohol is good for you. For a long time, we focus on moderate drinking, etc. So we'll see where that goes. And here you get more information about the conditions there. And I'm beginning here now to highlight for you spotlight on obesity. Right? If you would look at that graph at the bottom, the graph at the bottom represents the increase in obesity among the population ages 15 to 64, right? Over a period of 10 years. Increased by over, I think it's 400%, and the children increased by 109%, right? Let me make sure I have my things correct, my years. Yes. Okay, so we have a problem. I mean, we have a problem that is growing, and we must address it. Do you agree we have a problem? These are the top countries ranked with respect to the highest female overweight and obesity in the world. You know, these are the kinds of rankings we don't want to be included in. But there we are at number 10. And notice, there are a couple other Caribbean countries as well, but we are at number 10. When we look at the overweight and obesity trends in the Caribbean, it's just like I just pointed out in Trinidad. The male, female, both, been increasing over the decades and showing no sign of even plateauing at this point. And all of the goals are to halt the epidemic. And by halting the epidemic, you will see that in the graph by the plateaus as they go across. And then as we sit here wondering, well, okay, so I'm sure, everybody knows somebody who has an NCD. Can I assume that? Everybody knows someone who has an NCD? Yeah, can't see the hands very clearly. Yeah, but
oh yes.
When we're looking at the NCDs, one of the really concerns is the point I made at the very beginning, like before. The childhood obesity is really, it's a crisis now. We have young children, ages 11, ages 14, getting diabetes, hypertension. Young children, right? Obese children. And what we have to be concerned about is the persistence of obesity from childhood to adulthood. So that nice, chubby baby that we have in the family, we love them, right? I mean, who doesn't love a nice, chubby baby? We just now want to say we want to have a healthy, chubby baby, okay? Focusing on the healthy part of it. Because look at that. The overweight adolescents have a 70% chance of becoming overweight, which increases to 80% if one or both parents are obese. We have obesity where 6-year-olds have a 25% chance of becoming obese, and 12-year-olds have a 75% chance. We therefore owe it to the children to control, to give them what they need to improve the prevalence of obesity in Trinidad and Tobago. So perhaps I'll stop there just to find out if there are any questions, comments. Anybody, thought of something as I was talking that we could clarify. Is this okay with you, Makeisa?
Yeah, this is.
Okay. If you would monitor the chat for me, I'll see if there's anything there. If there's not, I'll go on.
Someone in the chat said, given the current COVID restrictions, limiting / discouraging movement, is there a rise in chronic illnesses, example, diabetes resulting in ulcer, amputations, etc.? This came from Sharon Monty.
Right. It's been a concern of all of certainly civil society and in the ministries of health, right? Because even in Trinidad and Tobago, where we've been fortunate enough to have a parallel health system, in addition to the population being less active, being stressed, and therefore eating more. I mean, talk to me about that. It's a expectation that the obesity level will be aggravated almost, as it were. But we can't allow that because we know that NCDs is a critical comorbidity for COVID. We know that persons with NCDs get far more severe disease and have a higher fatality rate than the persons who don't have NCDs. So I say to many people, now more than ever, we have to control NCDs. More than ever. I mean, I think the population has seen where, when we talk about the importance of health to development, I think that lesson has been learned all across the world. If you don't have a healthy population, your economy can actually come to a halt. We never contemplated this, but the economies came to a halt, right? Families suffered, deeply by sometimes 1, 2 in a family dying. And if you recall, when the minister gives the statistics and Dr. Trotman gives the statistics, we inevitably hear that many of the deaths, if not all, many of the deaths, most of the deaths are persons with high morbidity. Up to now, I think we are still having persons dying who are old, but I think Dr. Trotman is telling you, warning us, that we're seeing hospitalizations among a younger population, right? And some of those people have NCDs. So it makes sense at an individual level and at a community level and at government level to put the emphasis, an effective emphasis, right? An effective emphasis on NCDs. What we have here are the determinants of health. We have to remind people when in public health, the best healthcare system in the world does not produce the most healthy population. We have a fair idea of one of the best, don't we? In the US, they have the best. But the focus there is on the treatment at a very high level of the tertiary care. If we're interested in promoting health, preventing disease, right, we have to focus on what we call the determinants of health. And these determinants, although I've listed them like this, they are in fact could almost be grouped, and they are interrelated within the group, and they are interrelated between groups. I promised myself I'll try to get the right diagram to say that. But you will see that it deals with the physical environment, right? Do we have housing? Do we have safe streets where we can walk? Do we have shelter where we can feel able to socialize with people? Is the physical environment in which we live appropriate, affordable? The other one, of course, is the socioeconomic side. On the economic side, we know what happens, poverty. People at the lower income levels have worse health. And we know also, so go ahead.
They have less access to it.
They have less access to so many things, to the conditions. I call these the conditions necessary for my health, right? I have to be able to work. I have to be able to make a good salary. I want to be able to have housing. I want to be educated so I can make the choices that I need to make, and so I understand the choices I need to make. And I can go down the list, right? And we know very well that the social environments, the relationships in families, the relationship between families and community, in fact, produces health, make people more healthy. We often hear that in elderly people that have good social relations, they may not be married, but they have really active social relations. They tend to live longer than persons who do not. So all of these are here that we are, to a certain extent, apart from number 9, modifiable. And so there's a link back to what we talk about, the modifiable risk factors. Those risk factors, specifically for NCDs, are in fact themselves influenced by these, right? I have to be able to afford the healthy food. The fresh fruits and vegetables, they often cost more, right? And so, if governments are not giving me that enabling environment, it's going to make it very difficult. So that is what we have to focus on. And so I want today to focus on the individual level. And I want us to look at it when I talked about the human rights issue, that the rights to health and our rights in the health system are in fact based on the human rights which our government has signed on to. And in the UN Declaration of Human Rights of 1948, it clearly says, everyone has the right to life, liberty, and security. That being the third article. And if we look at the 25th article, it says, almost like summarizing what I just said, everyone has the right to a standard of living adequate for the health and well-being of himself and his family, including food, clothing, housing, and medical care. Medical care is just one. And the necessary social services and the right to security in the event of unemployment, sickness, disability, widowhood, old age, or lack of livelihood in circumstances beyond his control. And that phrase we would often just sort of pass over in the past. But that phrase has now taken on new meaning, where you have lack of livelihood because of circumstances beyond your control. That's what happened with COVID. Right? That's what happened with COVID. People tried to in our survey that we did, people in cooking more at home didn't make an effort to eat more healthily. Right? What was very important for us to note is that people in that survey did not, there was not certainly an alarming percentage that felt that they had to adapt their medicines because they did not have enough food. And of course, we have to give credit here to the fact that some key medicines for chronic diseases through CDAP is free, right? That is something that we should be proud of, hold on to, and never let it be decreased. Let's make it more effective. And of course, in the Declaration of Human Rights, we have particular age groups or groups of the population that need to be taken care of, especially at times, mothers and children, as we all know very well. The last part, although I said you would think it's not related to health, believe me, it's related to health, in that the children, whether born in or out of wedlock, they should enjoy the same rights, the same social protection, right? The same health services, and have no difference as they grow older. The right to health was then enshrined in the Constitution of the World Health Organization. And I think you must have seen this, heard about it a lot. We talk about it all the time. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic or social condition. Right? That's our right. Right, regardless, and as we have here, they would also talk about gender, and it is our hope that the WH is working towards the understanding of it is gender and sexual orientation. That constitution really is the kernel that guides what WHO and we in public health do, right? And so we want to be able to understand that. We also want to see that interpreted in the constitution of our own country. Our constitution does refer to faith in fundamental human rights and freedoms, but health is not singled out as a right in our constitution, as it is in several, certainly in Latin America, and some in the Caribbean itself. It's not singled out as a right. But the minister makes the point that while this is so, the policies of the government, this government, and I would think it's fair enough to say governments over time, have supported the provision of the conditions that is necessary for health to the population, both, all over the, regardless of administration. They do it in different ways, they do it in different extents, but they have done that, notwithstanding the fact that health as a right is not in the Constitution. Now, we have to understand that when that is said in the Constitution, it's not a right to be healthy. You don't have a right, as I say, you don't have a right to be bright. You don't have a right to be healthy. What you have a right to is the conditions for the education and the conditions for the health that allows you to maximize the gifts that God has given us, each and every one of us, as we go forward. So where does that fit in to what we have in Trinidad with respect to NCDs and health in general? I often see this posters in the health centers. Do you all see them? Charter of Patients' Rights, Ministry of Health. It's like, it's just long. Yeah. I just went through and selected some that I would think is really important for you all to focus on, to monitor. Okay, one of the points I want to make is that working with groups like UNFPA, ourselves, and with respect to the NCDs and other groups, right? It is important to monitor whether this is happening. Not just talk about it in anecdotes, but that is all good, especially when something is alarming, but be able to face the government with the data, right? Face the government with the data. How many persons in your community, LGBTQ community, have had difficulty? What has been a result of that? Has a person who has not been able to access care, in fact, got their hypertension went out of control? Those, either as case studies or data, is what we need for the advocacy. And we're here and we see here that they read well. They read well. Access to treatment, respect, private and confidentiality, personal safety and security. But we have to make sure it's not just words as we go forward. They go on, freedom from abuse, right? To be protected from mental, sexual, and physical abuse in the health system, right? And be able to have the right to know the identity and of the professionals, fine. And then number 7, you'd right to receive information about your diagnosis, treatment, prognosis. That's a right. If you have to accept responsibility with the government for your health, how can you do this if you don't have the information? And how can you do this if you don't have access to the health professionals to be able to educate you about what your issues are? And in fact, prevent what we call late stage disease, but rather to catch diseases even before they manifest themselves. And of course, the right to communicate people in and out of the health system as we go forward. And here, I just want to come down to number 13. I almost wanted to put the last one in red. That these rights, they do reflect, if you recall, what it says in the Human Rights Declaration. But there is responsibility on both the side of the provider as well as the side of the client or patient. And one of these responsibilities, in order to improve the system, is the right to file a complaint when you consider your rights have been infringed. And I would add the right to file a complaint, and you have a right to get some feedback from the provider, whether it is a RHA or a hospital or the ministry, on that complaint that you have made. So it's there in black and white. I can't wait to hear from you all. Is this working for you? Are you able to refer to these when you have difficulty in the health system? And perhaps I'll stop there because I'm going to go on to another part of this. So tell me, what is it like to try to get health care in the system? In the primary care system, in the secondary care system, what is it like?
Karen, I could jump in here. Hi again, it's Sharon. I recently completed a rapid needs assessment of the healthcare system, the perspectives of LGBTQI for family planning. So I'm now in the process of analyzing that data. But what we're seeing is, and we had 216 respondents over 7 days. That was the length of the survey. We didn't have a lot of time.
Okay. Wow, that's fantastic.
what we're seeing is that most people would rather go to private doctors as opposed to public healthcare because they fear discrimination, etc. And then we also have where they feel that their needs are not being met in terms of the types of services that LGBTQI people require in terms of PrEP, in terms of gender reassignment, medication, etc., etc. So I'm hoping that will provide some insight to what you're talking about here this afternoon, and that should be coming out pretty soon. And FPATT's intent is to do a position paper to present to the Ministry of Health on their concerns. Thank you.
That is fantastic. That is great timing. That you all will have this information. I think I dare say that it is the sexual and reproductive health services that are, I think, the most difficult for you to access. Am I correct? As again, going to get a vaccine, for example.
Indeed, and especially since we're seeing that a lot of younger people are not defining within the classic boxes of male or female, you know. And so when we talk about gender sensitive care and yourself reflected in the healthcare system, people are saying when they go, they don't see any brochures, any advertisements, anything that reflects them. So, you know, you feel like an alien, right? And so, yeah, so that's key. If you're non-binary, if you're a non-binary person, where's reproductive health for you in the healthcare system? You know, that language is not even used yet.
Yeah, and we, I think it is going to be important to make inroads in the training of the healthcare professionals. And so it would be interesting after you have, for example, this survey to discuss it not only with the Ministry of Health, but with the Nursing Council, with the medical faculty and the medical board, right? Of medical board and medical faculty of UWI, because it's, you know, it had the issue has to be addressed through many different angles.
Agreed, absolutely agreed. I'm making notes while you're talking.
Okay, any other comments? I think I see two there.
As being a part of the healthcare system, there really isn't anything in place for persons of the LGBTQI+ community. Like, I don't even think the professionals know how to engage with them because they're so accustomed and they were taught one way. So I believe that education really needs to be implemented to them. If like with the upcoming who is not there as yet, and then for the persons who in the system, we can have like seminars, workshops, and bringing everybody up to on one common ground. That is, when it comes to patient care, and we want to have quality care. We want to have the best patient outcome. So in order to do that, we need to have the tools and the understanding and the education in relation to the patient rights. The RHA I work for, all is considered. We even have a department for number 13. Yes, you are right. We give you the information. If you want the person name, everything is followed through, and they actually have feedback. They have cases. If it's to that level, they will take it to that level. Like right now, the goal is patient care and quality patient care, and like not everybody is perfect, and that's in some instances that needs to be the results. Sometimes you need to go all the way and you need to take the necessary repercussions, because at the end of the day, we deal with people's lives, and it's not just a physical life, it's also a mental life, and certain experiences scar people as Sharon rightfully said, look, our community, they don't have any faith in our public health, and there's a lot of stuff that is available in the public health that they really don't know about because nobody engages with us, nobody shares this information. They just have one tunnel mind to what they think it should be, and it's not that. And we need to evolve as a nation when it comes to healthcare. It's not just binary anymore. It's an entire umbrella. It's more inclusive.
One of the things that I could see that might be useful with if the RHAs they have I know the quality care units and they have the complaints. I also know that each RHA is supposed to have I think it's an annual meeting with the community, right? It would be interesting for them or useful for you all for them to ensure that they report on the percentage of complaints that have been satisfactorily, according to, of course, the patient, right, satisfactorily addressed. And if they can begin to identify what percentage of those complaints were from the LGBT community.
Yes.
Yeah. So I think just that little, you have to get the wedge in, right?
Yeah. You have to take that extra mile.
Yeah. So using what is happening, doing the big things like the training and reorientation of the training, which takes a little while. There's some things that you can do when information begins to float up and people begin to hear terminology and so and understand the terminology, right, over time. And I think number 13 is one of the places, not the only place, but one of the places that could help, the fact that it's in there as in the Charter of Patient Rights.
Yeah.
Okay. If there are no other comments right now, Makeisa, I'll just go on. I'm looking at the time. I know that you will have to stop soon. And so what I wanted to bring to your attention for the next part was the fact that if you understand that the determinants of health are in fact, as if not more, Michael Mahmoud says more important in the healthcare system, then the right to information at the right time for us to make the right choice in the food that we eat is critical. I just remind you of those and remind you that unhealthy diet is an important risk factor of all of the things that are here. And I want to say, let you know that I'm sure you've heard that I'm very sorry for this very terrible slide, but I'm technologically challenged. But what you see here is how many people have heard of the Port of Spain Declaration? I can't see hands, but can you put in the chat?
South.
That's a great one. Okay, the Port of Spain Declaration was a political declaration that came as a result of the summit, which is the highest level of meeting that the heads of government could have. And the first ever summit on NCDs was held right here in Trinidad. I say right here in Trinidad in 2007. It's the declaration, as known as Port of Spain Declaration. There are 15 commitments, major commitments, and in fact, at the very end, it is that it establishes the Caribbean Wellness Day. There are groups working with the ministry have been monitoring to what extent the government is, in fact, have been implementing these commitments. And did I get the other one? No, unfortunately, I did not. This is not all. They monitor certain indicators around alcohol, tobacco, nutrition, the health system, etc. And will try to get to you all the actual PDF so you can share it. You will see that the countries, including Trinidad, have been doing quite well with respect to things that are in the health system. But the things related to the determinants of health that we have to do through collaboration with other sectors, this is what you begin to see. See the red definitely overpowering the green here? It's the reverse on the other side. So I wanted to bring that to your attention. And if we to focus on, if nutrition is an issue, we just talked about obesity at the beginning, nutrition has to be an issue. The flip side of that, of course, is you have to be able to have access to do physical activity. But let's just focus on the nutrition for now. And in order to address this, the regional institutions, CAFA, working with UWI, working with PAHO, and I think FAO and others, provided a brief to the ministers of health and the ministers of trade that provided guidance on what countries could commit to the policy level. There's a policy brief for this, and you can get it on the CAFA website. I have highlighted number 1, mandatory food labeling, because it's been in the news. Have you been hearing about it? Yeah? Has anybody been hearing about food labeling? Any hands going up, Makeisa? Or chat responses? Respond in the chat so we could know.
They didn't hear about it.
They really have. This is one of my concerns that we have overall. These policies are in fact policies guided by WHO and PAHO. So all the countries in the world are proceeding. They call them different things. In the Caribbean, we call ours a 6-point policy package. And with respect to the mandatory food labeling, in recent time, the governments have been working at a regional level to come up with a standard that would provide the kind of labeling that makes it easy for people to understand what's in the food. I'm sure you all know about the nutrition labeling at the back. It's very technical, it's very informative. It tells you how much sugar, how much this, how much added sugar, etc., etc. Between you and me, I tell people, there's only one thing I really know and look for every time, and that is the percentage of the dietary fiber, because it is the simplest one that I learned from long ago. I don't remember these other portion of sugar, portion of this, and then sometimes the sodium is in one way, and it's giving you a salt and a sodium, etc. So the countries have investigated and come up with what we call front of package labeling, which says we need to have something on the front of the package, because in the groceries things are packed, so the back of the package is in the back, right? So we need something on the front of the package. We need something that has already done the interpreting and the work for us. So regardless of your level of education, regardless of whether you're rich or poor, you can easily see what is in that food. You don't have to calculate it for yourself. It says high in sugar, high in fat, high in saturated fat, etc., etc. And in Latin America, we have the evidence, both in Latin America and the Caribbean, because Jamaica has done a fantastic study that showed that this particular system is the most effective system when it comes to the front of package labeling. And there are many reasons, that's a whole other thing. But because of the size, because of the shape, because of the fact that it's black, it does not, in fact, it's not complicated. It does not get into all the coloring that the package has itself. So it stands out, right? And then the white on the black makes it very easy to see, even those of us who need their glasses when they go shopping. But I want to come back to why we have to insist that this thing takes place. Because it is a human rights issue. We have, from the very level, we have a right to health. You saw where the declaration listed that. And then we have, in this case, we have other, there are treaties and covenants that are relevant. We have the Covenant of Civil and Political Rights. We have the Convention on the Rights of the Child, which clearly talks about the right of the child to health and to be provided with a healthy food, etc. And we have the International Covenant on the Economic, Social, and Cultural Rights, which talks about not only having food, but using indigenous food as important in terms of, so that the indigenous communities are in fact not at a disadvantage as we go forward. And in fact, as we benefit, as I give the example, quinoa is an indigenous food, which now somebody told me is too expensive for the indigenous people in Bolivia to buy. So it's the indigenous foods are good. Many of them are good, not all, many of them are good, and we want to be able. So all I'm highlighting here is the right to health and the right to information and the right to be able to have a food plate that is palatable or is in keeping with my own social and cultural environment, right? It's my right to be able to have that. It's a right. It's not I feel like. And we have to highlight this for the governments as we go forward, right? This right to health and the right to information in particular is at the heart of this front of package labeling, because the principles of participation and accountability and transparency, right, is at the heart of the rights-based approach to how governments are supposed to be making the decision. And these schemes, as I indicated just now, there are different kinds of schemes. And what are they aiming to do? They want to enable the consumer to be informed. They want to raise consumer awareness of the foods that are high in sugar, salt, and saturated fat very easily. They want to discourage the consumption of food high in sugar, salt, and saturated fat in light of the linkage between the poor diet, obesity, and NCDs. But here we have an idea of the kinds of different systems we have. We have the proof that this system is the most effective. It started in Chile. Chile has fantastic research. They have all the figures that we're showing the decrease in consumption, and they're beginning to see the decrease in obesity in certain populations, in certain age groups in the population. And Mexico has done the same, and they too are beginning. They have already seen the reduction in consumption of sugar-added beverages. So we know that. We also have the evidence that says this particular system is much more effective than these. You see how complicated these are?
Dr. Sealey, so
Yes,
Michael is saying he have been hearing from time to time on a advertisement on labeling. He would like to see a drive to help or encourage people who sell food for the working populating in the city zones provide more healthy foods. Currently, the choices for healthier food meals are limited. He would like to see a total ban on cotton candy, which is made from poor melted granulated sugar and coloring.
and often fructose.
Yeah.
Right,
We often hear drive moves to ban soft drink and fast food. Cotton, well, I guess cotton candy is like eating 40 spoons of granulated sugar directly out of the pack.
Absolutely. So
Yeah,
we have to work together as a society to have.
But like within the healthcare system, like within the hospital, they do that, right? So they don't sell any carbonated drinks. They remove all the carbonated drinks out of their machines. They try not to sell them. See, they still try to cheat by selling the diet ones, but it's not supposed to be there. So
Right.
that is actually a movement that they try to enhance and decrease the NCDs in Trinidad, like enhance proper nutrition and like implementing like physical activity programs, like it have the aerobics they normally have after work competitions, like health promotion programs where the biggest loser is you see companies trying to implement healthy standards and to decrease obesity, poor nutrition, and just they're trying to have like healthier staff and healthier beings.
And what we need to say to the government, especially, I don't know what the position yet is of Trinidad government. Jamaica has, in fact, reversed their very positive one at the beginning, and we can guess why. We're going to come to that in a little while. But what we need to do is to, in fact, really have a campaign, as your colleague is saying, right? And one of the ways that we can have the campaign is simple, taking a page out of how in terms of the tobacco control days when we had a lot of advocacy. And perhaps this is something that we can do, and that is to have on our website where everybody can load photographs of where there are advertisements. Because one of the things, if I go back, you will see they're not supposed to advertise the children. And sometimes you see on the school fence, right? On the school fence, you see the advertisements right there. So if we just simply took pictures and put them on our website, and if people would upload, I think those are the kinds of things we'll begin to see governments and manufacturers sit up.
need to get accountability.
Accountability is key, absolutely key. And so here, I'm not asking you to read through this. I just want you to know that this right to health and the right to adopt this front of package warning has actually been recommended by Special Rapporteur on the Right of Health, which is a person who works with the Secretary General of the UN on the right to health and makes a report to the countries every year, twice a year, I think. And in the one in July last year, specifically talked about the fact that the right to information is what must drive the front of package labeling that the countries and the society is demanding. And that governments have an obligation, if they have an obligation to protect the right of health, given the prevalence of these diseases and the epidemiology of NCDs, they really have a right to make sure that the food is labeled so it prevents consumers from making unhealthy or maybe making healthy and informed choices. So you can guess what happened, right? As we try to promote this, the countries got together, they have a draft, all of the countries are supposed to vote on it by May 31st. They extended it to June 15th in some cases. I'm not too sure how the countries have come in. But meanwhile, the food manufacturing companies have resorted to and threatened litigation. Of more concern to us in the Caribbean, because we're small, is that they are able to influence the governments. I don't say, we're not going to discuss how, influence the governments as to what direction that the governments can do with respect to their policy. And WHO and PAHO and CARICOM adamant, and we must be adamant, when we talk about whole of society, it must include the private sector, but not at the table where policy is being formed, because it's a conflict of interest. I mean, it's fairly clear to most of us. So we've seen it. We know that some of it is beginning to happen in the Caribbean. We are hopefully going to get some data on that soon. And so this is what you have to be aware of. And it's groups like yours working together, simply putting forward in the public domain, right, the issue and talking about how important this is for your health, right? I mean, NCDs, as you know, is linked to, on its own is a problem. With COVID is a problem. NCDs, and I didn't talk about that, it's all linkages with HIV. The HIV itself and HIV, the drugs that are taken for that. We can't afford to have governments that are, almost want to use the foot, Jamaican term, pussyfooting around. But governments that are not making decisions that are in fact in the interest of them, especially the children's health as we go forward. So you have children, you have sisters, brothers, you know what that is. I'm just putting up here for you again what that those labels would look like that we want to have on the packages. And we are indicating here, in fact, that there was a front of label packaging campaign on the social media. We participated, most of the countries participated, and there was almost, I mean, for the last 2 months. So I encourage you to look on the Healthy Caribbean Coalition website, and please look on our Facebook page, TT-NCDA page, because we're going to be developing this further as we go forward. And sorry, go ahead.
So Sharon added that more effective labeling is critical. In terms of lower literacy, also education is needed because many people are program shoppers. They pick up what they always pick up. We need a culture shift and education around looking at labels. And Michael added, there ought to be a right legal stipulation for label prints to be big enough for people to read. Expiry dates ought to be highlighted. Food inspectors are needed to do impromptu visits. And then Sharon added again, rather than adjusting the ingredients in food, the fruit producers opt for litigation to stop our right to knowing what is going into our bodies. Are we really surprised? Are we really surprised?
Yeah, well, we're not surprised, but we know we have a right. You know, yes. This is not a I feel. I have a right to this. We know we have the evidence, and I think that's what we have to put out there for the population to understand. We have the evidence, fantastic evidence, right? That front of label packaging works. This one works much more easily. I know very often they say, oh, that's because it's in Latin America. We have, Jamaica has a big study, a big project. They have undertaken the research, demonstrated that the population made the choices more quickly, made better choices, of course, made the right choices as we went along, and it also affected them, facilitated the actual shopping, as they said. They sort of put them through a trial, a trial situation with making choices in different goods. So we have it there. And we, TT NCDA, Trinidad and Tobago NCD Alliance, made up of these 9 founding members, really are working on our objectives, right? In terms of, especially number 1 on the top there, advocating for the implementation of multi-sectoral policies on programs and quality services for the prevention and control of NCDs, monitoring and evaluating the implementation of government commitments. Now, these, those of you who have been involved in the HIV movement or any other similar movement, I just got some lovely flowers. They would know that I've often said, that I recall that these were some of the things that we had to do at the beginning of that movement. And for example, building capacity of NGOs to understand what, all that is happening. We in fact plan to have a webinar, a capacity building webinar towards the end of the year, most likely in November, on that with respect to around this whole issue of front of label packaging. But more, we've had some, but we think, just as a comment that was made here, we have not done enough educating about what it is this thing is really all about. And of course, to create a platform, that should be a platform, not missing a T and an F for dialogue, etc. And the Alliance looks forward to more people joining and helping us with our advocacy agenda, which has 4 pillars: human rights and social justice, prevention, treatment, care and support, and meaningful involvement of PLW NCDs. And just like in HIV, it talks about the persons living with and affected by NCDs, because we know the caregivers have a lot of stress and a lot of depends on those, especially the unpaid women who stay as caregivers home. So we are working and would love to work with you all towards an NCD-free TNT. And that's the end for me. Yeah.
So Michael added, it is important to encourage individuals to do their part to manage their choices. While we know government have their roles to fulfill, we must not scapegoat them for all bad choices and bad habits. I am fighting to reduce my sugar intake, ice cream, night eating, etc.
Yeah, I mean, it's a cultural shift, huh? Yeah. It's a cultural shift, and we have to remember that and recognize that we need to help each other, that as we prepare the meals for all the celebrations, etc., to what extent we can gradually just provide at least alternatives to have some healthy food as well as the unhealthy food. Some of the food we eat is very healthy. I mean, if we rice and peas is a nutritious thing if we do it in the right way and not put the pigtail, or do like, I have to give you this joke about the helper. I had a helper who I tried to tell her in the callaloo, please, I got to cut down on the fat on the pigtail. I like the pigtail. And she just nicely trimmed the fat off of the pigtail and put it back in the pot. So she thought she understood what I said. So, but it is, yeah, a sweet tooth, maybe. Teeth. Yeah, but and we grow up on that. That's the other thing.
Yes.
We grow up on that, and that's why we have to help the young children.
And another habit we have is like after we have our meal, we must have a dessert. I don't know where we get that from.
I hope my husband is here. I mean, I don't understand. You couldn't get it from the table. Your meal is not complete, right? Unless you have something. So I hope that has, stimulated some thought, and I'd love to hear the comments from you all. More comments.
Dr. Sealey, I was wondering, right? So if someone is diagnosed with an NCD, is it possible? I know you say it's chronic, meaning like it's a long term, but could they with the preventative care that we have, could we attack the predisposed persons that it doesn't evolve beyond becoming to chronic? Like if we get it in the acute phase and we work on it, that it could be reversible. Like someone who is predisposed to diabetes and they're, as they say, borderline at the time, if we catch it early, could we increase exercise and change diet and see a decrease or a different route in their prognosis?
Yes, absolutely. And we say, but that's why we always tell my children to make sure that you know your family history. Because I think most people know if they have diabetics in their family,
Yeah.
Because the needs of diabetics are very open, and you either see them taking their tests and testing their blood glucose, or but you don't always know people who are hypertensive. So we should, if we have relatives that we do know, the amber light at least should go on. If my mother and my father are hypertensive, or my mother and my father diabetic, I need to just start looking at what I'm doing. And we also need to recognize the other one that we don't see, we don't talk about, is the cancer. But because cancer especially cancer of the breast, right? Obesity is a factor in cancer of the breast. So we have to see it as it's a great bang for your buck. If you look at just those 4 and see how you can tweak, I say to people, just tweak your lifestyle. Each month or each quarter, just tweak your lifestyle. Don't try to do, I can tell you, don't try to do it all.
Don't cut it out all at once,
right. But
small adjustments.
And then also work with friends, not just family, but get together, a support group, talk about finding out when do you eat. I keep saying, been saying this for years, not only what you eat, but when do you eat? What causes you to have these cravings? And how can you deal with those? And there are ways that you can deal with those. Yeah.
So Michael said, yes, it is a cultural shift, must confess. At the first phase of COVID, when we could not go out and buy food, I was cooking. Once food was selling again, my cooking stopped. Helpful tip to those who cook: everything can be cooked in water and not oil, fats, and butter. With the right herbal seasoning, food can taste just as good. And Faye actually asked, isn't obesity a factor in most cancers?
In many cancers, many cancers. Definitely with the breast. I think it is with the liver, right? Lung, and so forth. So, yeah, it's one that we don't normally
especially liver, because I know most obese people have the fatty liver syndrome,
right?
And that adds to the a risk in cancer.
And we have to look at our alcohol.
Yep.
Yeah, and in your group, check the group. When you're having your parties, it's amazing how much we consume. Amazing, and we binge in the alcohol. We don't have a glass of wine a day. And I always tell people, you cannot bank alcohol. You can't say, oh, I don't drink during the week, but I have 15 drinks in the 2 days of the weekend. No, that's not how it works. So.
Oh, I don't drink during work, but at the end, when I get a break, you drink again. So you make up for all the time that you wasn't drinking before.
Right. Yeah. So I hope that you all, we are here in the Alliance, and to the extent that we can work with you all, I know I have to give FPA time to do this part. So I'm going to come to close here, and I look forward to working with you all. Thank you very much. Thanks.
Thank you so much, Dr. Sealey. We asked that in the presentation that you share with us, can we have it?
Sure. I'm going to just allow me to tweak those typos and so that I made there, and I will send it.
Thank you so much. We like
Okay,
to post it on
I'll
the
send it
website.
to Ava at FPA, and she will get it to you.
Okay, thanks a lot.
Okay,
We
all right.
really
I wish you
appreciate
all
you
the
coming
best.
on and teaching us and edifying us.
Not at all. Not at all.
I really
Love it.
appreciated engaging and learning a lot from you. It was really nice meeting you, and we thank you so much for your information and your time.
Glad to be able to do it, love.
Thank
Okay.
you, Dr. Sealey. Thank
Angelique,
you.
over to you. Okay, sorry. Go ahead.
Thank you, Dr. Sealey.
Yes, thank you, Dr. Sealey.
Hi, good afternoon, everybody. Yes, it's afternoon. Dr. Sealey, you have me feeling so guilty. I don't even feel like talking because I feel like I could put myself on one of those graphs where everything just went up and up and up. But, the perfect time to do anything is now, not yesterday, not tomorrow,
Yes.
no.
Yeah.
So I'm procrastinating too much. So
Yeah.
that's one of Trinidad and Tobago's greatest thing that we could do, procrastinate and drink.
Procrastinate and find an excuse for everything not to do it.
Yes, exactly. So ladies and gentlemen, those looking on, I'm going to be speaking to you not about non-communicable disease, but something else that concerns our population. And at one point in time was just as worrying as our COVID-19 pandemic. So first of all, let me introduce myself. I am Mrs. Angelique Chotalal. I am the clinic coordinator for the Family Planning Association of Trinidad and Tobago, lovingly known as FPATT or FPA. So FPATT has been here since 1956. So for those of you who don't want to do the maths, that's more than 65. That's going into 65 years, right? So it's older than me. And we are a human rights focused, non-governmental organization providing sexual and reproductive health services to women, men, adolescents, boys and girls here in Trinidad and Tobago. And I'm happy to say that today FPATT is noted as a preferred provider and a trusted advocate amongst key populations that include members of the LGBTQ+ community, sex workers, youth, and Spanish-speaking migrants and asylees. What I'm going to speak to you about, or my conversation, is going to be connected with HIV. So in 2003, FPATT became a Ministry of Health approved HIV testing site. And since then, we have conducted over 16,000 tests, a significant part of which was an uptake by the key populations. And in 2016, PAHO, along with WHO, did an assessment and saw that FPATT was well aligned towards the 1990 HIV continuum of care, which is now 95, 95, 95. So according to the UNAIDS, in Trinidad and Tobago, there are 11,000 persons living with HIV. And of those living with HIV, 7,800 persons are on ART, which means they're on treatment, medication. Now, remember I mentioned we're going towards this continuum of 95, 95, 95. And those who would have been on in the first session, you would have realized that in 95, 95, 95 represents 95% of our population knowing their HIV status, whether you're negative or positive. And then 95% of those persons are on treatment. And then those who are on treatment, 95% of that are virally suppressed. So I just mentioned to you that out of the 11,000, 7,800 are on treatment, and that makes up 71% of their population. So we are lacking there. And of those that are on treatment, 7,200 are virally suppressed. and that works up to 92%. So that's not too bad, but still we haven't reached our 95 target. And there's another little fact I would like you to know. We have 2,300 orphans due to AIDS, not HIV, but AIDS. So we still have something to be concerned about. We still have something to do. And with COVID-19 now, we have seen a huge restriction. Due to the restrictions, we have seen a huge reduction in the number of persons being able to access testing across all of the sites of Trinidad and Tobago, especially with those community sites being most affected. So in response to this, the Ministry of Health, HACU, and NAC has looked into what can be done. And so there is a new vision. So because we have to end this epidemic by the year 2020, that is the global that's the global agreement that we end this epidemic by the year 2030. So the National HIV Policy Green Paper, which is in 2019, identifies combination prevention approach as emphasizing prevention across all modes of transmission, adopting a life cycle approach towards prevention of new HIV infections and STIs through behavior change and regular and appropriate and correct communication, having combination prevention programs, and also having a focus on youths and key populations such as sex workers, their clients, MSMs, the LGBTQ plus communities, prisoners, and migrant workers. So this is the whole prevention program that we are going to look at. FPATT has years of quality service, and we have been established as a trustworthy provider to the key populations. So with that in mind, we will be partnering with the Ministry of Health, NAC, and HACU to begin this combination HIV prevention program. So what we are going to do, we are going to reach approximately 10,000 persons with HIV-focused information, education, and communication material. We are also going to provide 1,000 HIV tests specifically to focus on the key populations. We are also going to identify 150 HIV positive persons who are new or lost to follow up, and this will be through our peer navigators. We are also going to enroll these new and lost to follow up persons who are living with HIV into treatment. And of course, with the assistance of our peer navigators, we are going to work with these persons so that they can understand adherence, stick to their medication, and move them to viral suppression within the shortest time possible. And it is with this new approach that we're looking at, this entire approach, that we are hoping that our national strategy will be envisioned and we will get rid of this epidemic by the year 2030. So I would like to say that FPATT being identified as one of the key clinics or key places where the key populations can feel at ease and comfortable, we are happy to be able to roll out this new strategy. And even more so, we are geared towards delivering all the objectives that we want to achieve, which is ensuring that we have an environment that is free from stigma and discrimination, and we already have that. We are going to improve access to quality HIV testing, with of course a focus on the key populations. We are going to establish a treatment and care site. We are going to implement and adhere to the standardized linkage for care, with of course our focus on our key populations. We are going to expand our current network to all the existing agencies that currently work in HIV. We are going to support HIV testing activities, such as outreach programs where there are what we call hotspots or highly populated persons within the key population. We are going to support our national policies and procedures, especially with linkage to care, through our peer navigation program. We are going to ensure there is a comprehensive integration of care and gender-based violence programs. We are going to distribute condoms, lubricants, and of course the antiretroviral treatment. And we are also looking to do what we can in terms of supporting behavior change and promoting the U=U campaign. We have, as I said, we have 65 years of experience in the field of sexual and reproductive health. HIV falls within that gambit. And our experience tells us that addressing such an issue as HIV and AIDS requires a multifaceted approach. And this we recognize, and this is one that our organization, FPATT, is full gear on to support, and we have the capacity to deliver. So we are looking for your support as NGOs and other organizations out there, and to the wider community that is logged on. I am saying to you, we are here for you. You are treated as one, respected as one. Your confidentiality, your privacy is well maintained. We treat everybody with the same love and care. We do not discriminate, we do not stigmatize. You are welcome. And if you need to get any more information, feel free to check us out. We have our website page, we have our Facebook page, we have our phone numbers, you have me, you have the other nurses and everybody else. We have some excellent peer navigators, some new projects that is really gung-ho on this, achieving this strategy, this aim by the year 2030. And that's it for me. Thank you very much.
Go ahead, Sharon.
Are we taking questions?
Always.
So we can, yes, we can.
Hi, Anjali. It's Sharon Motley. How are you doing?
Hey, hi, Miss Motley. I'm good, thank you.
Sharon is fine.
All habits I had.
I have two questions. When we talk about the numbers of people that are infected as opposed to the number of people on treatment, and I understand the aim of 95, right? But my question is, if I'm HIV positive, does it necessarily mean I am ready, that I need to be on treatment? Or is it when my CD4 count or the viral load, is that not a factor regarding whether or not I go on treatment? That's my first question. And my second question really is an observation. When we talk about getting people on treatment and adherence issues, we have to always remember that we don't live in isolation, right? Especially in terms of COVID-19, where people are unemployed, people are concerned about homelessness and all the other things that sometimes takes priority, especially not only to HIV, but to healthcare in general, right? So our primary concern is how we getting food on the table, making sure we pay the rent, taking care of those children who no longer in school, but they're all around and making noise in my head. And those are factors that sometimes impact people's adherence and health-seeking behaviors in general. And so that's my second observation. And the first one was just about, if I test positive, do I now need to immediately go on treatment, or does something have to happen to move me into treatment? Thank you.
Thank you very much for the question and the observation. So in regards to the question, so whatever a person decides to do, it's not a mandatory thing, it's their choice. What we do advise in terms of when you are positive to have that linkage to care, where we can check your blood count and see your health. Depending on the findings from that, the physician will now say, listen, you have these options. Your immune system is very good, the CD4 count is good, the immunity is good, so you don't need to, but here's what you need to do, or here's what we recommend you do. So it's not a mandatory thing, because remember, we cannot force anyone to accept care. It has to be the decision of the person. But it's always good for that person to know that there's support, there's concern, there's someone who cares, and to be in that system where in the event that that extra support is needed, it is there. So it does not necessarily mean, yes, going on to antiretrovirals, because I had a few clients that are just fine and they've been positive for years and they're not on treatment. So the option is really up to the person. In terms of your observation, that is so very true. And I have to applaud the Ministry of Health in terms of providing the medication and the support care for those persons living with HIV free of charge, because I tell you, it is not cheap. But we do recognize that persons, even though have challenges, for example, being able to go to the different clinics to be able to get their medication, transport, who's going to see about the kids. So there is a recognition of those challenges, and there are plans in the works in terms of going out to the persons. So there's some of that already happening. You cannot come, we understand. You have commitments, you can't be taking time off every time from your job every 3 months or whatever to be going to collect. And you know, we try to get everything where you don't have to wait a whole day, you know, you kind of like come in and it's just a half an hour time, but then you have to think about transportation time. So when you think about it, it could be a whole half day. So trying to alleviate all of these challenges, we're looking at all of the challenges and how best to mitigate them. But it is a working process. And this is why I say, you know, it's so important to have all hands on deck in anything we do, especially when we're looking at a national issue. So it's a very good observation. And yes, we really need all hands on deck and more input, and getting the feedback from those persons as themselves are very important. Thanks so much for your observation.
Nice seeing you again, Miss Angelique. So I wanted to ask, is it possible that someone could be like too far along for treatment? Like their viral load so high that is that a possibility?
That is a serious medical question, and it really depends on the medical health of the person at that time, because you hear of cases where persons were given the unfortunate prognosis and they defied it. So that's you know, nothing is impossible, and it's as I said, it's a combination. It's the person's self-belief, and it's the care that is given throughout that will determine what is the outcome. So that's why I say it's so important to have that supportive care.
Yes.
And you know, like our peer navigators, they may be strangers in the beginning, but they become friends, and they are so useful and so helpful in helping that person to navigate our no, let me not say ridiculous, our challenging healthcare system, right? So, you know, sometimes when you're faced with life-changing situations or situations that you're not ready to deal with, sometimes it helps to have a helping hand. But even that isn't forced upon people. It's all up to the person.
Can I just jump in, Makeisa, because to just reinforce with a story, years ago, I took a friend of mine he wasn't feeling well, and I took him to a private physician, and he tested HIV positive. I then got him to MRF within a few days. His CD4 count was 4. His viral load was over 1 million. I remember the doctor at MRF saying she did not know how come he was still alive and he was still working. He was under 100 pounds and he had sores all over his body at that point. Fast forward, it must be 9-10 years now, undetectable.
Wow.
It's become clear he need to lose weight every time he checking his So I am telling you,
that's marvelous.
I mean, and I always say though, his lifestyle choices. So he's not an alcohol drinker or doesn't smoke cigarettes either. And so it goes in sync. So once he got on his medication and he goes to all his appointments and he takes his medication every single day, he does not even have a mark left on his skin. And I am telling you, I remember sitting there next to him when they said CD4 count was 4 and viral load was in the millions. You cannot tell today, undetectable. So it is, for me, it is never too late unless you're already in the coffin. Thank you.
Wow, thanks for that, Sharon. Anybody have any other questions? Well, guys, thanks for being here yet again. We're having so much fun today. I am overwhelmed with joy of how much stuff I'm learning. FPATT has bought me. I'm definitely coming on board with FPATT after today. I would like to thank everybody for logging on and interacting with us, coming on and talking. I would like to say a big thank you to Ms. Anjali again and Dr. Sealey, just for giving us this knowledge that could make us better and better our lifestyles and let us know our rights and how we can navigate through life healthy. And I'm seeing that a lot of questions is being answered and everybody's really satisfied with our health here so far. So I'm very happy. And join us next for cancer at 3:30. See you all then. Bye, guys.